Right, so thank you very much to the organizers. I was given a topic of which I know nothing about, which is great when you're given that topic and told to do it anyways. So I will be talking to you about something which is completely different from our previous speakers and in which I learned a lot. My disclosures are online if you're really interested in that board. The other part is I did not show up, and thank you, Jonathan, for suggesting this title. I knew that I was going to be given something. So here's our first polling question. I know it's afternoon, you've had a big meal, it's dark in here and quiet. So please go ahead and get out your iPhones, or for some of you, Blackberries, if some of you. But here's who's with the following team will win the Stanley Cup. I will tell you, I submitted these in advance, so there is no opportunity. So let's go ahead and vote. Not the Flames ever again. I'm from Edmonton. Oilers, Oilers, Oilers. You have no choice but to vote. So please. There is none of the above because there are no other teams, but thank you for asking that question. Right, so let's see what people think. Yeah, looks like the Oilers. I'm going to go quickly through that. There we go. Just before anybody else could answer. So here are the learning objectives. We want to talk about the features common to atrial fibrillation and heart failure. I want to discuss about beta blockade may affect heart failure differently for AFib and heart failure, and I'm going to show you something that you'll hopefully will be somewhat provocative, and then contrast cases where it's a complication of AFib or vice versa. So this is another lesson I learned from at this very conference a few years ago when I was debating Peterloo. He showed a very cute little fuzzy chick, and I nearly lost the debate despite the fact that he knew nothing about what he was speaking. But so this year I chose to do the same, is I know nothing, so I'm showing a nice little picture. But what very important is the chicken or the egg. So I actually decided to go to a much darker spot, and this is a Japanese dish, Donburi, and this is actually the translation roughly. I am not Japanese, so forgive me if it's not exactly correct. It's parent and child Donburi, so chicken and egg. So you're going with the flavor where we're going to go here. So sorry to take you to that dark space right after lunch. So AFib and heart failure share a lot, and I think one of the themes you'll get from this talk is that if you just replace the A with the H or vice versa, you are really talking about very similar diseases, a 1 in 5 lifetime risk. The prevalence in Canada is around 2% of the adult population. The cost is huge, both financially and to patients, and then it increases with age and other risk factors, which we think are very similar between the two. Most importantly, as many of your clinicians, you're thinking, you know, when one develops the other, as in they have AFib, they develop heart failure, or they have heart failure and they develop AFib, it always amplifies the problems. It's not just like you just treat it and it's okay, it always makes it harder to manage. And so I've put up the very title there, it's something called a syndemic. And so most of you are saying, great, I know about pandemics or epidemics, but what's a syndemic? So we're going to come back to what a syndemic is. So before we do that, I want to ask you, in patients with atrial fibrillation, what's the rate they develop heart failure? So how often are patients with AFib developing heart failure? So here's the answer is A, less than 1% per year, 2 to 5% per year, 6 to 10% per year, or 11 to 20% per year. And in true multiple choice fashion, you see I didn't go above 20%. I even gave you an upper limit. You couldn't get it wrong. So please go ahead and answer so we can see what you guys think. I know you're all going to be eagerly awaiting the answer. Right, so many of you think it's about 6 to 10% per year developing it, and I see this live action polling. It's like the French election, or the BC election for that matter. I'll show you the answer in the next little bit. Second polling question, all 3 drugs, and I say ACE broadly, ACE, MRA, and beta blocker, prevent patients with heart failure from developing atrial fibrillation. So I very carefully worded this, that they're in sinus, and then what drugs prevent them from going into atrial fibrillation. Do all 3? Yes or no? It's a very simple question, and you can say, I don't know, maybe one does, maybe one doesn't. I don't really care. It's a yes or no binary outcome. So let's see what people think. I go to these quickly so you can vote with your peers, be influenced by your peers, only vote for the one that's the majority. That's great. So good. This is, most people don't think that all 3 prevent atrial fibrillation. So let's see what the answer to that question is. So back to syndemics. So what is a syndemic? This is a term you've heard probably for many of you the first time today, and for many of you the last time today as well. This is what we call a synergistic epidemic. So A syndemic, and there's a great Lancet issue on this entire topic just in this last month or a month and a half ago. The hallmark of a syndemic is the presence of 2 or more disease states that adversely interact with each other, negatively affecting the mutual course of the disease trajectory and enhancing the vulnerability, and then they're made deleterious by their experienced inequities. That's a mouthful, but effectively in this nice little pretty picture in box A in the top left-hand side, you'll see there's 2 epidemics, A and B. One could be AFib, one could be heart failure. And they don't just, this was an example from HIV, they don't just affect each other as in they come from the mutual place of the same shared risk factors like in B, but they actually influence each other's trajectory. So they may share some risk factors, but once they're present and in the presence of the other, they really magnify or amplify the actions or the outcomes. In this case, they're talking about many things about HIV, but I think in AFib and heart failure, we'll kind of try to bring it a little home about what are those things. So first of all, how are AFib and heart failure related? So if you start on the left where I like to live in the heart failure world, you'd say, well, it increases left atrial size, which increases the pressure. Some functional MR is created. There's decreased left atrial contraction. That leads to AFib. So heart failure can beget AFib by just doing those things. Then if you kind of follow around to the right, from AFib going to heart failure, you can have decreased effective cardiac output. You can get a tachycardia-mediated cardiomyopathy just from increases in the heart rate alone. And in the middle, fibrosis and neurohormonal inflammation occur in both states. So they could actually both lead or be led to the same pathway. Well, that's really great. There's a nice article in Circulation which covers this topic, and I adapted their figure. Well, the other way they're related is through things that we often don't think about, sympathetic tone, and this is bidirectional, AFib to heart failure to AFib. TIMPs and MMPs and natriuretic peptides are markers of fibrosis or markers of other, the matrix or fibrous tissue that makes up the heart. Those things are affected by both disease states, and in some ways, and sometimes they are trying to compete with each other. And finally, the other markers we know a lot about, aldosterone, angiotensin II, both disease states are independently act on both those pathways, including cyclic GMP, which means that you could probably target many of these and maybe prevent both or one or the other. They're also related in the ways I think as clinicians we think about a lot. I think our patients think about this a lot. I'm really happy to see patients in the audience. Again, I will absolutely apologize for putting you to sleep. As a patient, we shouldn't do that in clinic either. I probably do that in clinic as well. But reducing mortality, important, reducing hospitalizations or the ER, keeping people out of the healthcare system in a bad way, and improving symptoms. We just heard 2 excellent talks about how do we actually improve quality of life, not just mortality as an outcome. So both AFib and heart failure are related in that respect. So does AFib produce heart failure? So let's think about that. So start in my favorite space, the left-hand side, the heart failure world, about 5.4% per year convert to AFib. That's about you take a ton of different publications, you come to about that average, and really you can pick 4 or 6. You can even pick 7% if you want, but it's about 5.4% per year. If you take people with AFib that have no LV dysfunction that's known and no known heart failure, it's about 3.3% per year developing heart failure. So these are not double-digit numbers, but if you think about accruing this over a lifetime or 5 years as a patient may see it, that actually adds up very quickly. And so the goal of all of our therapies should be prevention, prevention, and prevention, so we need to think about what things can do that. This is from the Framingham heart study, an oldie but a goodie, but you kind of can look for this type of data because it's very helpful. On the left-hand side, you see the first incidence of heart failure in patients with known atrial fibrillation, and on the right is the other side. The curves look almost identical. You could almost interpose them and you wouldn't know the difference. It just means that they happen to develop at the same rate and they happen to develop in the same substrate. When you look at it in the Olmstead County, you might be asking, well, what percent develop preserved systolic function or preserved EF heart failure versus low EF heart failure? Well, on the left is preserved, on the right is reduced. It looks like it's about 60% preserved and about 40% reduced, or 39%. Most clinicians would say that seems about right. At least it has kind of face value. Interestingly enough, in the Olmstead County study, they show the different years, and this is like they have a massive data set they can look at. It really hasn't changed that much, which also is striking that we need to think carefully about what we're doing. In the Orbit AF Registry, which is on the left-hand side, the incidence is about 1 to 2% per year developing heart failure in people without heart failure at the baseline. And importantly here, it's linear. It doesn't go away. There's no high risk early, low risk late. It is very linear. And there are some risk factors for developing heart failure. So if you're in the AFib world, what would be an outcome? Well, heart failure would be an outcome for a trial. And if people are on permanent AFib, that's more likely to develop heart failure. Also, higher heart rates, about a 7% increase on beats per minute. So there are a couple of features which predict the development of heart failure later. So the AFib guys might say, well, this is important, we got to focus on that, and we see it from the other side, but we shouldn't ignore each other. The common issues that come up clinically, and I will not talk to the clinical aspects, this is about recovery and other things, but these are the common things that I think we see in every clinic visit. How much do I slow this patient's heart rate? There are trials to talk about that, and the rate control trials, RACE and RACE2 and a bunch of others. Do I cardiovert the patient from AFib to sinus rhythm? There's a talk on that tomorrow that I think Hisham is debating, so I won't even talk about that today. Do I anticoagulate? Of course you do. That's not even a question. What's your stroke prevention strategy? What drugs or devices do I use? Well, that may depend, and I'm going to show you a couple of slides on that. And I won't talk about devices at all, and that's not because I don't like them, but I just didn't make any slides on them. Which is causing the symptoms? So how do we attribute blame? We like to blame stuff, like is it the AFib causing it? Well, I'm a heart failure doc. It's got to be the AFib. It can't be the stuff I'm doing. So what about heart rate? Well, this is just showing the difference between atrial fibrillation and sinus rhythm, AFib on the left, sinus rhythm on the right, showing that for the same heartbeats or beats per minute, they have different risk strata depending on what their rhythm is. So in sinus rhythm, it matters a lot. In AFib, it probably doesn't matter nearly as much as we think it does. And I'm already sorry because Hisham's looking at this saying, man, I was going to show that slide. So here it is. Sorry about that. So beta blockers. Well, it looks like beta blockers reduce new onset AFib in patients with heart failure. So that's actually a good news story. This is one of the many examples from, this is from the Merit HF trial with long-acting metoprolol. They just prevent new onset AFib. That's pretty straightforward. It's an old message. It's pretty straightforward. Well, what about ACE inhibitors? I think if I polled you on this question, you would have probably said yes. Well, Anik Dusharm, this is one of her papers, so I just highlighted it because it's nice to have a good Canadian contribution on this. Shows that enalapril in the SOLVE trial prevented the new onset AFib, and it did it in a very robust way. So you can prevent AFib in patients with heart failure using an ACE inhibitor. Well, that's another good news story. You know I must be getting to some bad news stories. So MRAs, well, same story. Eplerenone, and this is in the emphasis trial, reduced the new onset AFib. And in a very nice paper in JACC just a couple of years ago, talked about AFib flutter, people crossing over, et cetera. Same message, so MRAs are good. So you can prevent AFib with a triple therapy, ACE, beta blocker, and MRA. So the answer to that question was yes, you can. Well, here's something complicated. Somebody did a nice big meta-analysis of all the beta blocker trials in HFrEF and looked at atrial fibrillation to look at does beta blockers in 18,000 patients have the same outcome effect in those trials. And on the left, you see sinus rhythm. Beta blocker looks much better than placebo. On the right, in AFib, doesn't look like there's any effect on the large outcome of mortality. So no effect on mortality of beta blockers in patients with HFrEF and AFib. And for many of you, you're thinking this is exactly how you feel right now. For those of you who have never seen these ads, they are some of the most priceless ads you can ever see, because that is how we feel right now. Tell me that's not how you feel. Okay. So when we think about beta blockers and FRF, they're kind of the cardinal agent that we use in our therapies. This meta-analysis is very well done. You cannot be criticized by the quality. But we have to look very careful at the hazard ratio. So I've said, you know, there's the deaths in sinus rhythm, deaths in AFib, kind of different. People with AFib die from different things than people with sinus, but it's not that different. But really, when you look at all-cause mortality, we're still talking about a reduction in AFib, and there it's about 7% with a confidence interval that does go above. One of the things is to be careful about looking at p-values, look at the hazard rates, the hazard ratios, and look at the confidence intervals, not the p-values. There is still a reduction, and it wouldn't mean that you just simply throw away beta blockers out of patients on a patient with AFib because there's no benefit. There are other outcomes in which it benefits. Just all-cause mortality in 10 trials, it didn't show the robust findings, so understanding the reasons is quite important. So don't throw them away just yet. Think about why that could be, and try to think through what our next therapies should be to help to understand this. This is my favorite down with Digoxin slide. Digoxin has absolutely no value in patients with HFrEF. really, it has got no rule unless you're stuck and you have nothing else. So it increases the risk of death in almost every cohort study, and small RCTs and even the DIGE trial didn't show any benefit. So I'm just going to say that's my safety slide. And in fact, here's 345 days without a digoxin recordable injury on the job. That's what our heart function clinic's sign should be. And my last slide is really just about stroke prevention. I know I'm flipping around a few things, but if you really want to prevent the big, hairy problem in AFib, it's about stroke prevention, and really direct oral anticoagulants are the strategy. There's really very few patients that shouldn't be on one. You got to search and hunt pretty hard to find that. So I would just, don't forget to stop the aspirin on these patients in terms of stroke prevention. So here's my final summary slide is AF and heart failure are commonly linked and amplified. I actually think there's endemic, not just co-linked epidemics. The outcomes remain poor if there's both AFib and heart failure, and therapy should be studied and applied carefully before you assume it works. So both Captain Morgan and that chick with the egg have the same stance, you'll notice. I'm not sure if those two are related, but that could be a syndemic. So thank you for your attention.